Good afternoon. Thank you for joining us to discuss Preparing for 988, the National Suicide Hotline Designation Act. I'm Lucia Marks, Vice President of Public Health at MTX, and I'll be your moderator today. Slide, please. Our agenda today includes providing some insight on what we do here at MTX and introducing you to our 988 subject matter expertise. After our discussion, we'll be sure to leave time to answer questions. Please feel free to send them to us via chat at any point during the discussion. Slide. MTX is a global technology consulting firm. Over 87% of our focus is on modernizing technology for public sector agencies. We are committed to serving the public and our communities and do so through organizations such as the 1% Builder Pledge, where we give back to local and national social causes through an ongoing commitment of staff time, technology assistance, and financial support. We work in a variety of industries and have subject matter expertise not only in healthcare, but education, human services, licensing, and credentialing, to name a few. Our speed to market sets us apart. What takes others months or years, we can implement in weeks. Slide. We have a presence in more than 30 states. Here are just a few of the agencies we've had the good fortune to work with over the years. Joining us today is Patricia Babcock. She's our Director of Strategic Development and Policy Initiatives. Abe Balsamo, our Medical Director in the Health and Science Division, and Ray, I always mess this name, Ray Cornelio, our Solution Architect in the Health and Sciences Group. Slide, please. So now I'd like to open the floor to our speakers today and have them introduce themselves and provide a little bit of background as to why they have developed this subject matter expertise in 988. If you could take it over. Okay. Thank you.
I'll go ahead and start. I'm Patty Babcock. I am the director of the Noble Research Institute. I recently joined MTX and took the lead on the Research Institute, but by way of background, I have a PhD in social work and I'm a licensed clinical social worker. I was the former deputy secretary at Florida Department of Children and Families, but prior to that, I co-directed the Center for Behavioral Health Integration at the Florida State University College of Medicine. By way of trade, I am a clinician, and for 10 years, I ran a 4-county behavioral health program in the Panhandle of Florida. I'm happy to be here. This is a passion of mine, a long-awaited change in the way we do business. Abe?
Thanks, Patty. I'm Abe Balsamo from New Mexico. I've got a background in medicine. I was trained in emergency medicine at the University of New Mexico and University of Nebraska. Currently, I'm the medical director here at MTX, as well as in a local correctional facility. My background and my love for this, I have some passion here because we see the mental health issues every single day, both in the ERs, with bounce backs, etc., but also in the jails situation. And so that's kind of where my focus has been over the last 15 years or so. I'll turn it over to Ray.
Hi everyone, my name is Ray Cornelio. I'm a solutions architect here at MTX. I originally began my healthcare career in mental health as a cognitive neuroscientist with a specialty in cognitive behavioral therapy. I later switched over to the administrative side and spent 13 years in hospital and healthcare administration, managing risk-based contracts and creating networks, including but not limited to behavioral health networks. Prior to that, I spent 10 years in the management consulting and private equity world. And I'm excited to meet everyone today. This is one of the topics that I think it's been a long time coming. And I think it's due time that we have an open dialogue on 988 and mental health services.
Thanks, Ray. Thanks, everyone. Just a little background on me. I've been with MTX now for almost 3 months. Prior to my time here, I was with the federal government, both with the CDC and with ASPR, the Assistant Secretary for Preparedness and Response under HHS, for the last 13 years. So we understand that most of us that are joining us here today already know the basics of 988. They already understand that it is the 911 for mental health, that it was signed into law in 2020, and that it is mandated to be implemented by July of 2022. You all know that there is an option in terms of technology implementation, that the government will be rolling out their own system sometime towards the end of 2022, potentially 2023. And you know that states will be anticipating about a 30% increase in calls starting immediately, and over the next year or so, they're expecting almost 10 times the volume of calls as what they've been receiving. Those of you know that this is long overdue, that mental health in America is at a crisis point right now with, due to a variety of factors, including, of course, the economy, COVID, social unrest, and that this 988 has the promise to make real change in mental health availability in the states. So with that being said, and I'd like to open up the floor to all of our speakers here today. Please, those in the audience, feel free to ask questions. They'll be shown to us throughout the time. What I'd like to do is open up a question to our panel and ask them, why is 988 important right now?
So I think I'll take the lead on this one, Lucia. Thank you very much. I think it's important because we've seen not only a massive increase in mental health disorders, starting from anxiety to depression to suicidality, etc., over the pandemic especially. But this increase has actually been going on since 2005 or so. It has not been linear. It's actually a curve that's going up pretty drastically at the moment. And as you touched on, probably because of the pandemic and all the things that go with the pandemic, job losses and job changes and people getting sick and basically all that's surrounding the pandemic. So, there's different things that I think need to change, and finally they will be changing. Leading these mental health responses with police officers is probably not the right way to deal with somebody who's in a situation that they may not be able to control themselves. When you're feeling suicidal, you probably have other things going on. And when we lead with police officers, it's the wrong type of response. And so that's one of the big changes that will happen with 988. We're going to lead with mental health professionals across the board. You might have some backup, so not to take the police out of the situation. They may be there, and the ambulance may be there, and the fire department may be there, but we're going to lead this response with mental health providers, which I think is it's due time. We need to do that. We know that there's a 16x, and I don't know how to say this nicely, but people who get shot by police during these responses, 16 times more likely if they have a mental health disorder. And so that's what we're trying to clear up here from a big picture as far as the response goes. Patty, anything else to add on there?
No, I think you said it. And it's a way for us. We typically talk about how we tax the law enforcement and the court system as well as the medical system, with our ERs, and we don't do a whole lot of conversation about the impact on the community and the school and the family. And I think 988 really does offer that opportunity for us to get the services and supports that the communities and the families and the individual needs. But there's also another piece in play here, is I think it also is going to give us an opportunity to think about how we are providing the right services for those special populations, those veterans, the LGBTQs, even the children and adolescents, and those folks in the rural areas.
Yeah. Abe, you were talking the other day about how the special populations, how they stand to benefit from 988. Could you go into a little bit more detail about that?
Sure. So, those special populations, the reason we call them special populations is because historically they've been left out of these big initiatives. So I think we have a chance now with 988 to really focus on the general public that always gets services, but also the kind of marginalized populations. And, the LGB community, they've already got a framework set up. The Trevor Project is a framework to support them in exactly this suicide response. The Trevor Project is very specialized for that community. And to the same extent, the VA has their own population. They will be utilizing 988, but may not be able to lean on the core 988 people. And so we have to keep in mind, we need people that know the VA, and the VA does have a system set up, so we need to connect them. Along those lines, and one of the probably the biggest populations, and I'm from New Mexico, so I see it every day, the indigenous populations in this country are typically left out. They're, we say they're sovereign nations, and for the government, that means we don't have to remember them sometimes. Well, that's got to change. Just because, quote unquote, they're a sovereign nation doesn't mean they don't need support. And these sovereign nations historically have been left out of these things. They have not gotten the funding that they need, and they don't have the right people on board. Even if they do access, if they access the system and they find somebody like myself who doesn't know the culture potentially, there's not that same connection. So I think we have a chance right now to be very focused about connecting with the right people to the right people, or connecting the people to the right people to make a real difference here. So that's kind of what I was talking about, Lucia.
Yeah, thank you. And actually, Ray, I think you can really speak to this, right? You are a mental health provider for the VA, is that correct?
Yes, yes. And I'm also a veteran, so I've experienced the VA on both sides. To speak to that, yeah, there's been plenty of situations of friends of mine and even myself where I've gone to it, and you would think that the VA is, the ideal place to have something that's clinically integrated where everyone communicates with each other because they're all in the same system. And more often than not, that's not really the case. It's kind of a very siloed approach, and I think that's going on in healthcare in general. But right now, we're in this stage where we're trying to bridge the gap between those mental health services, the social services that are needed, and really taking a whole person approach to healthcare, not just dealing with that one circumstance where we have to call 911, then the person in need gets Baker Acted and never receives any of the services that they actually can. I mean, in the VA's instance, that happens more often than not if they're experiencing like a severe episode of PTSD, or they've gone into a very depressive episode. I've personally had friends that have either committed suicide or attempted to commit suicide based on deployments that we've been on, and just adjusting back to the real world. And while there are great providers in the VA healthcare system, it's still like we've all mentioned before, kind of a fragmented approach.
Yeah, yeah. To that point, do you believe that 988 has the chance of changing the way we react or respond to mental health emergencies?
Absolutely. I think it begins with us having this open dialogue to have those conversations and see what that need is. It's a huge step to me. It's a huge step in the right direction to start that dialogue and really look at things from a different perspective. Our current system is fragmented, and doing this is not only going to help the patient or the person in crisis, it's also going to help law enforcement have those conversations, receive that training. And then the healthcare provider side, which is sometimes not really spoken about, there's burnout and there's mental health issues there. There's the same kind of issues that are occurring in entrepreneurship, which is very quiet. Nobody ever talks about it, but there's a lot of entrepreneurs that have taken their own life that are very depressed because of the stress involved with their day-to-day operations. And then also for the caregivers, I think expanding into the ability to bring those caregivers into the conversation and really open up that dialogue with everybody in the room is going to be key in properly implementing a 988 system.
Yeah, absolutely. That's a great segue to what Patty had been talking about recently about the caregivers and about the kind of resources that they are in need of, and how 988 may be able to provide some of that.
Right. And if you think about that true system of care, and mental health really is a family issue. It's not just the patient issue, and so as we're thinking through or kind of reimagining how we deliver services, really embracing, like I just said, it's not just the family, it's the community itself, and as you alluded to, the numbers are going to grow exponentially, and Vibrant talks about, 3 possible populations that we will be serving. And one is that addressable population. And those are those folks that have mental health issues and or substance abuse issues, as well as those folks that have been exposed to traumatic events. And, and this kind of ties into that VA piece as well, and some of the other special populations. But it also, that addressable population also embraces the family and the caregivers. And then that second population is that serviceable population. Those are the folks that are in a suicidal crisis or a mental health substance abuse crisis, currently, but they're really not known to the system. But now 988 gives an opportunity for them to get ready access to a mental health professional. And then the last one is those folks that we currently serve that are really, taxing the law enforcement as well as our ERs, and so they're already using our lifelines both on the regional and kind of the local level. But we, if you really think about what 988 is supposed to do, it's supposed to do 3 things: offer someone to talk to, offer someone to respond, and offer somewhere to go. I mean, that's beautiful. I mean, that is something that, you think about a system of care. This is what we've really have needed for so long, and try to break down some of those silos and fragmentations if we can.
Yeah.
Right. And
Yeah, well,
one of the things,
I'm sorry, go ahead, Abe.
if I can jump in, Lucia, thank you.
Sure.
One of the things that we're seeing a lot that I think is different with 988 is, I think we can all agree, and in America, we can't agree on anything except that the medical system's broken right now. And this is a chance to do it right. This is a chance to really think through it and provide a patient-centered care model that touches all of these people, touches the family, touches all your different providers, so that we can really give the person in need the type of care that they need right now, rather than these one-way referrals that you, as a clinician, I say, I gave them a referral. If they didn't follow up, too bad. That's what's broken about medicine right now. And I think we have a chance to fix that. So I just wanted to touch on that, because it's not just medicine, it's definitely in mental health. We see it all day long.
Yeah, absolutely. So, of course, whenever you're breaking down silos, whenever you're trying to do something that's going to affect, large populations, there are challenges. What do you feel the challenges are to implementing the 988 system?
So personally, I think some of the challenges are getting people just in general to do things differently. It's always hard, this change enablement. We have to help people learn a new way of doing their job potentially. And that change takes a minute to get used to. But I think that model of change is good. We need to be changing, we need to be evolving, and we need to be providing outcomes at the end of the day. So that's one of the big things that I see. That's going to be hard, but we need to do as a group, and we all have to be kind of pushing in the same direction. Our thought leaders, our government leaders, the people on the ground, boots on the ground, we all have to be pushing in the same direction.
Yeah. Ray, with your expertise in the hospital world, what do you see as some of the challenges to the system?
Well, I would start off, before getting into the hospital side, I'd start off speaking to the social stigma behind it. Even in my past experiences, having been deployed to Iraq several times, and in the time frame that I did it, this is 2003, 2004, 2005, and 2006. When you left that deployment and you came back, I remember having conversations with my senior officers saying, you're not experiencing anything, you're not having any nightmares. They're essentially having a conversation with me saying, this is how you're gonna fill out your form when you're getting back, because we don't talk about these things. PTSD, or back then I think it was still referred to as shell shock, is not something that you experience. That's something for weak-minded people, and we're not weak-minded people. So it's different now. So overcoming that social stigma and having those conversations, I think it's going to help relieve societal pressures for people to be able to reach out for mental health services. And I think technology is going to play a key role. I think nowadays it's much easier for somebody to use SMS or a self-service portal to kind of vent and have those conversations, as opposed to especially in a COVID world now, as opposed to getting in their car and driving over to see a mental health provider. Sometimes you go and you think it's going to take you 30 minutes and you're there for 2-3 hours and half your day is gone. And I think now with 988 and creating this kind of system, it's going to help a lot more people gain access to mental health services.
Yeah. Well, Abe, let's talk about where the rubber meets the road. How are states going to actually pay for this? What are the challenges that they're facing there?
Sure. So we've been running around talking to states, 20, 25 states so far, and this comes up every single time. Where are we going to get the funding? Some states see this as kind of an unfunded mandate, whereas others see it as a kind of funded mandate, but nobody sees it as fully funded yet. So there's a lot to be done. Some of the things, there's some interesting ways to fund this that we're finding, and we can certainly help some of our state and local people find the money, but people are tapping into their mental health block grants. That's not one place that we all know there's money sitting there from SAMHSA. You have to earmark it. You have to show them what you're doing with it. So, and I think everybody knows about the mental health block grants. SAMHSA and Vibrant funding, obviously, that's coming down. There's implementation, there's planning monies there. The planning monies are mostly dried up at this point because everybody should have presented their plans in early January, but there's funding coming down to implement at this point. Also, a lot of states are tapping into general funds because they know this is a big initiative. If as a country, this initiative is probably going to cost in the ballpark of $350 million to implement. But when you take it from a society level, 350 million, but you're going to save about 4 billion per year to the society. Now, that's not individually, that may not be to your agency, but if we look at it society-wise, that's a very small investment. I will personally give you $350 million if you give me 4 billion. That's kind of what they're looking at. And then there's some others that, depending on the states, and depending if it's an election year, and depending sometimes if it's a blue state or a red state, there's other funds. The telecom fees, we're seeing kind of a sweet spot around 25 cents. You don't get too much pushback from your constituents. You don't get too much pushback from the telecom companies. 25 cents on the telecom bills seems about right to most people. And the best model that I've seen is really, we only are putting that on cell phone bills because these are the people that typically are paying $25 to $125 a month for their cell phone access. You don't necessarily want to go after the people that are buying prepaid cards because those are the same people that might need the services, and a quarter might actually be a lot of money to them. Those are the things that we're trying to keep in mind here as we're working with legislators and people at the state level, and trying to come up with the best model to do this. Now, certainly paying yourself back is another option, and billing for the first time is enabled in 988 for all of the mental health services that you're providing. That's something that we've thought through very carefully because Medicaid, Medicare, and probably the private insurances are all going to be sources of reimbursement for the system, so that it's sustainable long term. Those are kind of the big ones. And then if anybody saw the president's proposed budget, lots of money for implementation of mental health in the proposed budget. So our job now is let's keep pushing that through the federal legislation to make sure that these funds keep flowing, because this is not a flash in the pan kind of thing. This is a thing that we've needed for 50 years, 100 years, and finally it's getting funded, but we need to make sure it's funded indefinitely rather than funded one time.
Right. Well, I think one interesting thing about the fact that this was signed into law in 2020, that year, overall suicides actually went down a little bit in overall populations, but in minority populations, for the first time in a long time, they started going up, which was typically, not the norm. And it makes us think about, what are some of the pressures that are facing people today? What are some of the pressures? We know that most people who call a suicide prevention hotline are not actually suicidal, but they do need help. They do need mental help. And it makes us think about, like I said, what are the pressures that are bringing people to the 988 line? What are some of the services that could be relieving some of the pressure that they are experiencing. So, the obvious thoughts are, what are the social determinants of health, and how do they, or into mental health specifically, and how do they feed into this issue?
Well, I think, and I'm going to go back to your challenge question, and I think that really ties into the challenge, and so I think about the challenges that we're going to be facing, and I'll dovetail it here to social determinants of health. I think about, whether it's going to be 4 or 5 T's, T's, and so the big thing is that timeline. If this is going to roll out, in July, hopefully states are thinking through some of the questions that you're asking. How are we going to address the social determinants of health? How are we going to address, maximizing our revenue and those sustainability plans? And then, how are we going to fit in the teaming and the training to make sure that those existing 911 call centers are working together with our 988 call centers, and we have a good plan and a plan for coordination of care, and we get folks trained on evidence-based assessments, and we've identified our providers, et cetera. And then for me, this is the timing piece, and this does fit right into that social determinants of health. We talk so much about no wrong door in behavioral health. But we have a lot of populations, as Ray said, just the stigma alone. How do we communicate to those populations that have been discriminated, that have not been able to access equitable care? How do we communicate to them what 988 is and isn't? How do we make sure that we have the right services and supports in place for those patients, and what is the timing to get that word out? Because as soon as we put the word out, as soon as we say we go live, we've got to be able to serve everybody that comes into that system. And remember, if you go back to what I said, this has really broadened the scope of who we're going to be working with. These are not going to be our suicidal, psychotic folks with extreme erratic behavior necessarily. And then how do we bring in that technology piece? And so making sure, as we think about technology and we think about interoperability and we're thinking about, telemedicine platforms, are we also thinking about that overlay of diversity, equity, and inclusion? And everything that goes hand in hand with making sure that we're patient-centric, if you will. And then, you can open a whole can of worms on the whole rural medicine piece, and the broadband issues there as well.
Yeah, what I find so exciting, as a public health person, we have an opportunity here to really address so many of those social determinants of mental health. We know that people, it's lack of housing, it's insecure food, it's a whole variety of social issues that often develop, kind of are behind people's development of mental health issues. And through 988 and through the technology that we can develop to address, to pick up these calls, we can also create linkages to so many of these services and take people to where they need to go to get their help. It may not always be mental health that they need help with. It may be food, it may be housing, it may be work. So we have the capability here to really take some pressure off the healthcare system and put it in the place where, we really have the best chance of meeting people's needs. So that's
that thinking outside of the box of traditional care. We traditionally don't think about getting the I call them the Maslow hierarchy of needs services first.
Yeah.
We go straight to treatment and don't think about, what are the correlates there that we could be treating as well.
Yeah, absolutely.
Yeah, and Lucia, to your point and to Patty's point from the technology perspectives, there's going to be a lot of serious introspection that's happening from these organizations. Being able to go inside and identify at a state level, county level, or city level, being able to identify what KPIs are going to be top of mind for the organization and how you're going to measure success is going to be probably the first step, followed by selecting a platform that helps enhance their current infrastructure. Obviously, none of the states, cities, or counties want to pick a platform that they're completely incompatible with. And having that conversation and looking at the requirements of it and how it fits into your current infrastructure is also key. And then lastly, taking inventory of all the resources that are going to be available. I mean, that's a Herculean task to begin with, just from getting mental health providers in a certain county. But now we're talking mental health providers, we're talking social services, we're talking domestic violence shelters, we're talking homeless shelters. There's so many things that are going to be at play here, and I'm really excited to see where it goes.
Yeah, yeah. Talk a little bit more about that. Talk about the technology and how, I mean, it is amazing that we have this opportunity, right? We're at this point in history where we have an opportunity to use technology to really connect people to the healthcare services that they need in a way, and populations that, you know, have always been at a distance and have you know, had such barriers to receiving help. Can you talk a little bit more? Can anybody in our panel talk a little bit more about, you know, what we stand to gain by having these robust 988 systems in place?
Sure, I can jump in here, Lucia. One of the things that we are going to see, and the way I think we have to think of 988 is similar to the platform. 95% or more of these cases will not be dispatched. That's different than 911, right? 911, they dispatch 90% of their calls. So if you call the correct number, there's a huge cost savings there, first of all. So that money can be reallocated as a society to other programs to help the people in need. So that's number one, I think. We have to think of this as 95% prevention and only 5%, you know, putting the Band-Aid on and getting them the care they need right now, and actual suicide intervention, because there's suicide prevention, which I believe is number one in public health. We want to prevent something from happening, right? That's 95% of what we should be doing in this system. The other 5% is the Band-Aid work and the let's intervene. Let's make sure that zero suicides is really our goal. And that's where a lot of our money is spent in medicine, is those emergency type cares. So if we can minimize that and do this right, just from a society level, if you think about right now, they all go to 911 and 90% gets dispatched. Next year, they go to 988 and only 3 to 5% gets dispatched. Think of that from a society level. How much money are you saving, and how are you offloading the police officers to do their work that they're really, really good at? How are you reallocating the mental health providers to really do work in real time, rather than having to, again, fix something after the fact, which is always harder. We know that, you know, prevention is the best thing we can do. So that's what the goal is with our systems that we're building. You know, certainly there's FCC guidelines that we have to follow. There's HIPAA guidelines we have to follow, etc. You know, all these, I call them green check marks, and those I think are going to be standard in all systems. But if you don't have that approach where we're really going after prevention here, then I think you're doing it for the wrong reasons, and you're going to end up with the same outcomes that we have right now.
Yeah, yeah, that makes a lot of sense.
And
Oh, I'm sorry. Please go ahead.
Thank you. To add to Abe's point, I think this is probably the first time in a long time that a system's been created where it's a single point of access, where we actually are going to have a centralized hub to view the resources, deploy the resources, check on the statuses of cases, see who's involved with the cases, and follow up on those things. I mean, with the technology alone, we're able to automate a lot of those processes where normally they'd be happening from a human perspective. And as we know, the price of everything's going up, talent included. And I think technology is going to, you know, a robust 988 system is going to really help us streamline those operations from an intake perspective and from a follow-up perspective as well.
That will,
You know,
that
and I
leads us to, oh, I'm sorry, go ahead.
And I think to just follow up with what Ray was saying, you know, as people think about, you know, scaling up, putting up this 988 system, you know, I think the other piece that technology can do is help folks with what I just network mapping. You know, knowing what networks are out there, knowing what services are out there, and really thinking through how the calls are going to be triaged in and triaged out. You know, and using technology to do that. You know, and it's a very different a different approach, and then, what's the sustainability plan? But I think technology, if ever there was a time for us as behavioral health folks, both providers and administrators, to think about what technology can and can't do, it's now.
Yeah. Well, that brings us to an excellent question. What are some of the challenges in meeting the 988 requirements right now? What are some of the states facing? I mean, we know one of them, right, is the percentage of calls that have to be answered. We know that, most states have tremendous difficulty answering even more than, half of the calls that they receive. Some aren't even able to answer more than 10%. So how can technology help states with that, meet those requirements? And what are some of the other challenges?
I think from a technical side, there's a couple of things that you touched on, Lucia. One is all of these calls have to be answered by a human being. And as we scale up, an extra 30% by the end of the year, and then 5 years out, looking at maybe a 10-fold increase in calls, those call centers also have to increase their capabilities. They have to be able to scale. And so that's something we've been looking into long-term. How do you get the right people in there? Because you need people with bachelor's degrees and de-escalation training to be answering these phones. You need mental health professionals at the master's level to be supervising those people. And you may need PhD and MD and DO type credentials to be the kind of medical direction of the whole system. And so to scale, typically we start with one medical director for every 14 employees, and then you go from one supervisor for every 14 employees, and then as you start to grow, the medical director position may need multiple people. So that's certainly something that we've worked on internally. There are organizations to work with similar to ours, and including ours, that provide staffing for that very specific group of people that you may need on the ground. So that's one piece of it. But also, how do you offload the people as you get more and more calls? How do you offload? Because we know 95% of these people don't need de-escalation. Maybe they need some de-escalation, but they don't need the full response. There's going to be a subsection that are there, and we've worked in Lifelines. They call because I'm a little depressed and I just need somebody to talk to, and these other things. And at some point, we can devise a system that you can offload some of those calls. You can offload them to automated chats. You can offload them to other things once you've already done the initial screening to make sure they aren't, in fact, suicidal. They're not at a high risk. They're the very low risk population who calls in. You can get them when they say, I just need a referral. Okay, well, let's make a system technologically that can get you set up in real time, but without necessarily having a body pushing all the buttons, because we all know that's slower anyway. If I call in and I say, I need to talk to a psychiatrist, you have the potential to just get them connected to the technology that will get them what they need. So I think that's another way to offload in the long run that everybody's kind of touching on right now. And nobody wants to say it out loud, because we all want to say, we're going to answer every single phone call and we're going to be on the line for 5 hours potentially, which does happen in Lifelines, but you can't scale if you're on the line for 5 hours.
Yeah, absolutely. Well, thank you very much. I'd like to open us up to questions from the audience. Does anybody have, and maybe Adam, if you could let us know if we have any questions from the audience. And in the meantime, let me just check here and make sure that I'm seeing everything that I'm supposed to see. In the meantime, we did have a question about from folks that are saying, I just feel totally overwhelmed. We're already overloaded. What are some things that you could recommend to help us prepare for July? Is there anything else along the lines of what you were discussing before?
That was yesterday when we were talking, just as a group, I said, this is that classic scenario where we're expected to continue flying a plane while we're building something new on that plane. It's still up in the air, and so that's the dilemma that we all have. We're already overloaded, and as we get closer to July, everything gears up, and it's hard to land the plane to take the time to fix it, and so how do you, I'm not a pilot at all, but how do you get to a cruising altitude at any point during the day and really start to think about within your communities, because it's not going to be a one size fits all even within your state. And so how do you start working, getting those community alliances together, getting those community groups together to map out where it's going to go, and what are the services that we have in place. And one thing that we didn't say, if we get the outcomes that we expect, and we're able to get the right services and supports in place, we won't see the frequent flyers at the rate that we're seeing right now.
Yeah.
And so I think if we can, it's going to gear up, but I do think it's going to stabilize at some point. And those communities that were really able to take the intent of 988 and implement it, the way it is intended.
Right.
And then, go ahead.
Yeah, no, I was going to say, here's an interesting question. We got a question asking about the maturity of the protocols for 988 operators. And they asked, are there national standards as with 911 or state, or are the standards set state by state? Who would like to take a stab at that?
Yeah, I can jump in there. So 988 is based on the Lifeline system that has been in place for a long time. There's 180 or so Lifeline call centers right now in the country. And some of those are going to scale to 988 because they do need to add more resources, more bells and whistles and things like that. But the basic training for de-escalation and how do you handle a suicidal call, that is going to be based on the model for the Lifeline systems that's already in place. It's something that currently we are working on also internally, because we'd like to provide that training to any organizations that may need the training also. So that's something that to think about if you don't already have it in place, because there will be a need for potentially overflow call centers. There will be a need to make your own call center more robust. And for those type of things, there is training available for that. And like I said, based on the Lifeline centers that are already available.
Okay, we're starting to run out of time. I'd love to get some closing thoughts from you folks. Maybe one closing thought per person. Who would like to
Go
start?
ahead, Patty.
Yeah, I'll kick it off. I've been doing this kind of work for probably almost 30 years. I do see a light at the end of the tunnel. I'm not sure it's going to be the panacea that we're all think it's going to be, right out of the chute, but I do think it is and it will be better than the system that we currently have. Like I said, I do get concerned about the timeline here, and being able to push this out. But I think if we continue to think about, how we can make the system better, we'll make a better system, for everybody and families and communities.
What about you, Abe?
So a couple things. I think if you don't shoot for the stars, you're not going to get there. You have to have big goals. And I think that's what 988 is. It's big goals. And if we land on the moon, cool. We made a big jump here. And so that's kind of the analogy I would say here. We really need to go after the stars. If we can get there, we know it's going to be awesome. It's going to be so phenomenal for the society. But if we land on the moon because we tried, hey, I'll take that. That's much better than where we are right now. So that's kind of my thought as far as that goes. I want people to keep it in perspective here that it may not be perfect as we roll it out. And I can almost guarantee you it won't be perfect. But if we have goals that we're really going after, we're going to get there.
Oh, thanks, Abe. Ray, can you give us a final thought?
Absolutely. And I agree with both Patty and Abe. I think really setting that baseline expectation is going to be key in what we get, at least rolling out in phase 1, phase 2, or however we're going to approach this. But getting that baseline and realistic expectation set is really going to help us identify things that are going to be top of mind and really dedicate the proper resources that are needed to answer those calls and answer the crisis situations. And most importantly, from all of these things in a new 988 system, we're going to get the data that we need to move forward with, to see where additional funding is going to be required, where additional help is going to be required, where do we need resources, are there gaps in what we're doing. And this is just, for me, I got out of mental health because of how fragmented the system was. And I went into administration in hopes of being able to fix it. So it's really opportunistic for me to see that all of this has kind of come full circle in the last few years. And I'm really excited to see where it goes.
Yeah, yeah. So I'll just say one last thing, and that is that, I mean, I guess if you're lucky to live long enough, you get to see problems be met with technology, problems be met with solutions that simply didn't exist before. And so I feel like, you know, this mental health need is at an all-time high, and we're in a point in society where we have technology. Of course we need people, of course we need compassion, of course we need, you know, the whole variety of factors to meet people where they are and be able to provide them help. But we're at a point in society where we have, you know, some new means by which we can meet those needs. And I find that tremendously hopeful. I'm tremendously hopeful and very optimistic that, you know, as Abe said, well, we may not, you know, hit the stars, we will be making movement, and we will be, you know, making movement towards a better place for mental health. So with that, thank you so much, everybody, for joining us today. I've really enjoyed speaking with you. And if anybody has any further questions about 988, about mental health, about how technology can help to meet the needs of either that 988 system or mental health in general, please reach out to us at MTX. My contact information and Abe's contact information is below. We'd love to speak with you. We'd love to talk with you further about what we've learned along this journey of developing our platform for 988, and learn more about what you're experiencing, especially those in positions in the local and state public health. Thank you so much, everyone. Be safe, be well, and we'll see you again soon.